Hello students, in today's session we'll be discussing common fluid and electrolyte abnormalities that we encounter in clinical practice. So the fluid abnormalities could be hypovolemia or hypovolemia. The electrolyte abnormalities commonly that we encounter is the sodium and potassium disorders. As you know, water is the most abundant constituent in the body, comprising of more than 50% of the body weight in females and 60% of the body weight in males. 55 to 75% of the fluid water that is there in the body is in the intracellular space, and around 25 to 45% is in the extracellular place. The extracellular is further divided into intravascular and extravascular. The intravascular is the plasma water, the extravascular is the interstitial. The ratio is 1:3. So the plasma accounts for only 1% of the entire body. Now the fluid space from the intracellular to the extracellular is governed by the Starling forces, that is the capillary hydrostatic pressure, the colloidal osmotic pressure, and the lymphatic forces that you would see. So let's discuss the first element that you have, hypovolemia. So hypovolemia is a state where there is a reduced blood volume, specifically the volume of the ECF, which can result in a decreased circulatory volume. Now the causes for hypovolemia could be multiple. So it could be GI losses in the form of diarrhea, vomiting, the GI bleeding could be there. Renal losses when the patient has a polyuria. It could be due to diuretics, it could be due to adrenal insufficiency, it could be due to osmotic, that could be due to diabetes. Third spacing, when you have the fluid which is moved from the extracellular fluid to it could have gone into the third space, that is the burns, ascites, pancreatitis, peritonitis. External losses like haemorrhage, severe sweating. So all these produce hypovolemia that could be seen. So what are the clinical features that the patients can have? So patients, based on the severity of the hypovolemia or dehydration, they can have symptoms. So tachycardia, hypotension may happen in moderate to severe hypovolemia, especially orthostatus hypotension. Supine blood pressure might be more than 100, but when your patient sits up, it will definitely fall. Dry mucous membrane, skin turgor will be slow. In severe form, the patients can have oliguria and renal failure. In children, you can see the sunken fontanelles, etc. So basically, when we have a patient with hypovolemia, we have to assess the severity of hypovolemia. So look at the vital signs, important, the blood pressure, the pulse rate, urine output is an important feature. Skin turgor can be used. The postural blood pressure, that has to be very clearly seen. Laboratory wise, you might have an elevated hematocrit that is there, elevated blood urea nitrogen to creatinine ratio, that would indicate a volume depletion. Urinary sodium concentration and specific gravity can be assessed to see the severity of the case. So how do you manage it? Fluid resuscitation. Isotonic fluid, that is either normal saline or Ringer's lactate, can be used. Colloids can be used in specific causes like sepsis or burns, that is albumin. Close monitoring of the urine output, electrolytes, etc. has to be done, and treat the underlying cause. If hemorrhage is there, find out the cause of hemorrhage, manage it. Packed cell transfusion, blood product transfusions may be needed. Sometimes if the patient has severe diarrhea, then we will have to treat the diarrhea, find out the cause for that and treat it. Diuretics, etc. need to be stopped. The next very important electrolyte disturbance that we very commonly encounter is hyponatremia. By far the most common electrolyte abnormality that you encounter in clinical practice. We define hyponatremia when it is less than 135 milliequivalents per liter. So 130 to 135 is mild, 125 to 130 is moderate, and anything less than 125 is considered as severe hyponatremia, or the patient has altered sensorium, we consider it as severe hyponatremia. Now hyponatremia per se, the mild hyponatremia, the patient may come with nausea, headache and vomiting, that could be seen there. Severe hyponatremia, the patient can be in coma, they can have seizures, they can have confusion, they can have cerebral edema that could be seen. Again, the symptoms of hyponatremia depend upon the severity, also how fast it occurs. A rapidly occurring hyponatremia will be more symptomatic, a chronic hyponatremia may be asymptomatic. The causes of hyponatremia could be due to multiple causes. It could be due to hypertonic or euvolemic. So, the causes of hyponatremia could be multiple. We classify the causes of hyponatremia based on the volume status and the urine status. So, you have to evaluate it in this form. So, whenever you have a low sodium, look at the volume status. Is there a hypovolemia? Is there a euvolemia? Is there a hypervolemia? Now, if there is a hypervolemia, that means the body water has increased, the total sodium is not increased to that level. So, look at the urinary sodium. If it is more than 20, it is kidney injury is the cause. If the urine sodium levels is less than 20, it's either cardiac failure, cirrhosis or nephrotic syndrome. So, these are three important causes where you will have to manage it appropriately. Euvolemic, that means there is no edema, so total body weight water has increased, but the total body sodium has not increased. Most often the urine sodium levels here is more than 20 in these cases, usually is due to SIADH. So, SIADH is by far the most common cause that you would get it here. It could be due to stress, it could be due to addisons, it could be due to hypothyroidism, and some drugs can produce it. If the patient has hypovolemia, that means there is a decreased bottom water and there is a more decrease in the sodium, that is called as a hypovolemic hyponatremia. Look at again causes here. Urinary sodium is what you are going to look for. If the urine sodium is less than 20, then it is either due to trauma or vomiting, diarrhea, extrarenal causes, third spacing, pancreatitis and burns. If the urine sodium is more than 20, that means the urine is excreting more of sodium, could be due to either diuretics, salt losing deficiency that could be there, bicarbonaturia, ketonuria, cerebral salt wasting, osmotic diuresis, or sometimes due to mineralocorticoid deficiency, that is your Addison's disease, you can have it. So, this is how you approach it. So, whenever we have a sodium low, look at the volume status, then measure the urinary sodium. Based on that, you can look into it. Now, as I said, SIADH is by far the common cause that it's there, which is a euvolemic hyponatremia. You have to rule out thyroid and Addison's. Hypothyroidism and Addison's has to be ruled out. Serum uric acid is low in these patients that you would see there. Now, how do we manage a patient with hyponatremia? Based on the cause. If it is hypovolemic hyponatremia, replenish the fluids. If it is hypervolemic hyponatremia, then possibly we will have to give diuretics, treat the cause, and maybe added salt has to be given. Euvolemic hyponatremia, fluid restriction is the main therapy that you would look for. If the patient is symptomatic, you will have to give 3% saline. Be careful in giving, don't correct more than 12 milliequivalents per day, otherwise you can have the osmotic demyelination syndrome that could be seen. Newer drugs that have come to the treatment of that are the Vaptans. So, Vaptans are the vasopressin receptor antagonist, are very useful in SIADH, can be used in hypervolemic hyponatremia, but never in hypovolemic hyponatremia. So, you have the tolvaptan, conivaptan, which are available. Tovalalpan is the most common drug that we use. Coming on to hypernatremia that is there. So, when you have a hypernatremia, basically we are dealing with sodium levels which are more than 145 milliequivalents per liter. Most common cause for that is the water loss. So, when there is a diabetic insipidus or the excessive sweating or diarrhea, in such conditions these patients will generally have sodium gain that would be manifested. It could also happen when you have a correction of sodium, rapid correction of sodium, hypertonic sodium that is given, or the salt poisoning, you can get it. So, clinical manifestation, usually these patients are thirst, they are restless and they can have weakness, and if the sodium crosses 145, the patients can develop seizures that could be seen. So, main important thing that we have to look for is whether the cause is diabetes insipidus or not. If it is diabetes insipidus, we will have to look for whether it's a central diabetes insipidus or a nephrogenic diabetes insipidus that you're looking for. So, look at the extracellular volume. So, if the extracellular volume fluid is increased, then possibly it is secondary to a hypertonic saline that has been administered. If the extracellular volume is not increased, minimal volume of maximally concentrated urine. So, look for that. if the water loss is there, so either it's a GI or a remote renal inaccessible cause that is there. If the urine osmolality or the excretion rate is more than 750, that means there's a dilute urine that is processing. Look for whether there is a response to desmopressin. The moment you give desmopressin, if the urine osmolality increases, then it is central diabetes insipidus. No change or minimal change, that means it is nephrogenic diabetes insipidus that you look for. So the main therapy here is to control the fluid. Since the sodium is going out, give solute free water. So give dextrose as a saline. So dextrose saline you will have to give either dextrose saline or the 0.4% that is give it here. Do not allow the sodium to correct it really fast. Make sure the sodium levels less than 145 is targeted. So the water deficits, estimate the total body water, calculate the free water deficit. So the seed water deficit is sodium minus 140 divided by 140 into total body water that is seen there. Administer the deficit over 48 to 72 hours, and the fluid of choice is dextrose, that's the or 0.4% saline, half normal saline that is there. Again, look at the ongoing water losses. So calculate the free water clearance. Various formulas are available. Insensible waters losses could be there due to sweating, etc. Approximately 10 ml per kg. Adjust to that, and total you combine these components and treat the hypernatremia. Very importantly. Coming on to the next disorder that we have is hypokalemia. So hypokalemia could occur due to variety of causes. So hypokalemia is when the potassium levels are less than 3.5 milliequivalents per liter, we call it as hypokalemia. So it could be due to inadequate intake, it could be due to shift of potassium into the cells. So the most common causes that we encounter where you have hypokalemia is due to GI losses. So vomiting, diarrhea, sometimes the diuretics when there is a loop diuretic given. Hyperaldosteronism, renal tubular acidosis can happen. Anabolic states like when you take a total parenteral nutrition, supplementation of B12 and folate acid, or you are giving a colony stimulating factor. Here the cells are rapidly formed, so the potassium is going intracellular. Metabolic alkalosis, again H plus is exchanged for your potassium, so potassium goes intracellular. Hormonal, as in case of alpha adrenergic agonist, beta adrenergic activity, thyrotoxicosis, insulin when you give, they all push the potassium inside the cell. Even caffeine and theophylline cause that. Also you could have barium toxicity, hypothermia, all of them can produce hypokalemia that you see there. Now the main symptoms of hypokalemia would be either ileus, the patients can develop ileus that could be happening there, and severe hypokalemia can lead to hypokalemic paralysis. So the patients can have severe hypokalemic paralysis could be seen. Again, the renal losses, various renal losses are there. Most often is due to diuretics. It could be due to salt wasting nephropathy. It could be due to primary or unilateral adrenal hyperplasia. Drugs which are the aldosterone antagonists can be given there, and that can be produced there. Cushing syndrome, Gitelman syndrome, Bartter syndrome, renal artery stenosis, all of them can produce hypokalemia as such. Apparent mineralocorticoid excess, it could be due to the genetic defects in the 11-beta dehydroxygenase or licorice or the glycine carboxynolone administration that can be there. Itraconazole, posaconazole can also produce that. Diabetic ketoacidosis, penicillin derivatives like penicillin, carbamazepine, those can be administered and that can produce there. Sometimes, very importantly, whenever hypokalemia is not getting corrected, it could be due to hypomagnesemia that could be seen. So once we have diagnosed a patient to be having a severe hypokalemia, make sure you take an ECG. ECG can produce prominent U waves you can see there. So we will have to start the supplements, but parallelly please do the evaluation. So look for medical therapy immediately and then start doing the evaluations. If it is pseudo hypokalemia, do not treat it. Otherwise, look for the history. Important things that you have to look for here is urinary potassium. If the urinary potassium is less than 15 millimoles per liter, then possibly it's an extra renal cause. If the urinary potassium is more than 15 millimoles, then we know it's a renal loss. And then you calculate something called as a TTKG, transtubular potassium gradient has to be calculated. If it is more than 4, that means there is a potassium which is excreted at the distal part. If it is less than 2, then you have the tubular flow. That means there is a osmotic diuresis that is happening. Now, once you know that it is a TTKG which is more than 4, look for whether the blood pressure is normal, whether the volume status is normal or not. If there is a high blood pressure and high volume, look for the aldosterone level. If the aldosterone level is high, look at the renin. If the renin is high, then you know it is renal artery stenosis or renin secreting tumors. So, if you have a TTKG more than 4, high blood pressure, high volume, high aldosterone, high renin, it's a renin secreting tumor or renal artery stenosis. Similar but low renin, we are dealing with primary aldosteronism, that is the Conn syndrome that is coming there. Now, if the aldosterone levels are low, next you check for the cortisol. If the cortisol level is high, we are dealing with Cushing syndrome. If the cortisol levels is normal, we are dealing with either licorice or Liddle syndrome, or we have something called as the SAME, that is the syndrome of apparent mineralocorticoid excess. So, that is one algorithm. When you have a urinary potassium loss, look for the gradient, and based on the gradient you look for aldosterone, renin, cortisol. Based on that you can go on to the values. Now, if the urinary potassium is less than 15, then you know it's an extrarenal cause. Look for the acid base status, whether it is an acidosis, alkalosis or normal. If it is alkalosis, we know that is the most important cause that we have to manage in that way. Coming on to the high TTKG category that is there, where your blood pressure is normal or low, look for acid base status. If there is a metabolic alkalosis, look for the urinary chloride. If the chloride is less than 10, then you know it is a vomiting or diarrhea that you are seeing. If the urinary chloride is more than 20, then calculate the urinary calcium to creatinine ratio. If it is more than 0.2, it is either loop diuretics or Bartter syndrome. If it is less than 0.15, it is thiazide diuretics or Gitelman syndrome. So, based on the urinary calcium to creatinine ratio, you can differentiate it. If the acid base status is showing a metabolic acidosis, it's possibly a renal tubular acidosis, either proximal or distal renal tubular acidosis, diabetic ketoacidosis or an amphotericin B. That is how you treat it. So, when we look into the potassium, make sure you do the urinary potassium. Look the urinary potassium. If it is more, calculate the TTKG. If the TTKG is more than 4, then we know look for the blood pressure. If the blood pressure is high, do the renin, aldosterone and cortisol. If the blood pressure is low, look for the acid base status. If you are looking at metabolic alkalosis, look at the urinary chloride. If it is high, then calculate the calcium and creatinine ratio in the urine. Based on that, you can look into if the calcium creatinine is more than 0.2, loop or Barters. If it is less than 0.15, it is thiazide or Liddle's. So, this is how you approach the various potassium. Now, very importantly, we have to understand that the potassium has to be supplemented. You can have oral supplement is mild cases. Otherwise, IV in severe hypokalemia, we will have to give it. Again, remember, through the peripheral lines, we can give around 20 to 40 milliequivalents per liter. In the central line, you can give 40 to 80. So, it has to be monitored and given. So, potassium correction has to be done. Coming on to the next important lethal electrolyte disorder that we have is hyperkalemia. So, hyperkalemia, when you have the potassium more than 5 or 5.3, is a potentially life-threatening condition because of the arrhythmias it can cause. Most often, potassium hyperkalemia is related to renal failure, but it could be due to potassium sparing diuretics, ACE inhibitors, ARBs, NSAIDs. Sometimes due to hemolysis, rhabdomyolysis, or sometimes rarely due to excessive potassium intake. Usually it causes muscle paralysis, but very characteristically it causes the ECG abnormalities. So, initially you have the tall peaked T waves that happen, then the QRS becomes broadening, then the P waves disappear, and then you have the QRS merging with the P wave forming the sine wave pattern, and then the patients can lead into ventricular fibrillation and asystole that can happen. So, various causes of hyperkalemia can be classified is based on the intracellular shift, which can be due to beta adreneric antagonist if you take it, or there could be a rhabdomyolysis, or if you take succinylcholine, digoxin, etc. that can produce there. Pseudohyperkalemia can be due to leukocytosis or in vitro hemolysis. Inadequate excretion, if you have a RAS blocking agent, which could be due to ACE, ARB, or spironolactone, eplerenone, or trimethoprim, triamethrin, etc. Decreased distal delivery, which could be due to heart failure. Hyporeninemic hypoaldosteronism, which could be due to various tubulointerstitial disorders like lupus, obstructive uropathy, tacrolimus, beta blockers, certain pseudo-hyperaldosteronisms, which could be due to various defects in the Q-lin, Kelch proteins, etc. Renal resistance to mineralocorticoid, which could occur due to various conditions like what we've already mentioned earlier. Renal failure, by far the most important cause, AKI or CKD. Primary adrenal insufficiency, which could be secondary to infections like tuberculosis or cytomegalovirus. It could be due to metastatic cancer, or it could be due to hereditary conditions, sometimes associated with polyglandular diseases or autoimmune disease like the Addison's disease that you look for. So again, remember, moment the patient has a potassium which is very high, you will have to start the patient on treatment, but you want to find out the cause. Always look at the transtubular gradient. If it is less than 6, that means the distal potassium excretion is less. Get the fludrocortisone done. Line alpha fludrocortisone you are looking for. If the transtubular potassium gradient is more than 8, look at the aldosterone. If the aldosterone is low, then we know that it's either it is aldosterone related. Look for the renin activity. If the renin activity is low, then it is due to drugs. If the renin activity is high, then it is due to primary adrenal insufficiency or isolated aldosterone deficiency. If the transtubular potassium gradient is less than 8, then you know it's a tubular resistance. It could be various drugs like triamethrin, spironolactone, pentamidine, calcineurin inhibitors. It could be due to sickle cell disease or pseudo hypoaldosteronism, SLE, etc. If the transtubular gradient is more than 8, then you know the tubular flow is decreased. It's most often secondary to the renal failure. Now, as we said, the management of hyperkalemia involves various urgent measures. So, the first of the most important thing, you stabilize the membrane by giving calcium gluconate, 10% 10 ml of calcium gluconate given slowly over 10 minutes. Start on insulin dextrose that will shift the potassium from extracellular to intracellular. You can give nebulized beta agonist, that is the salbutamol or albuterol. Make sure you can avoid the potassium diet. You can bind the potassium by giving K-bind that's there. And also diuretics, sodium bicarbonate can be given for acidosis, and the mainstay therapy sometimes is emergent hemodialysis. Students, in today's session, we discussed about the fluid and electrolyte abnormalities, the hypovolemia, hypovolemia, sodium disorders and potassium disorders.